Good morning, everyone. Thanks so much for coming along. Before we get started, I would just like to do a welcome to country. So Abbott would like to acknowledge that we're meeting on the traditional country of the Kaurna people of the Adelaide Plains and pay respects to the elders past and present. We recognise and respect their cultural heritage, belief and relationship with the land. We acknowledge that they are of continuing importance to the Kaurna people living today. So my name is Rachel Hanrahan. I'm the product specialist for Abbott Core Diagnostic Immunoassay products. And I'd just like to start the breakfast symposium by giving you a bit of an introduction to Abbott and sort of what we're looking to get started with here today. So Abbott is a really big organisation, and perhaps if you're not in the sort of medical scientific community, you've maybe not really had a lot to do with our core diagnostics division. But overall, Abbott has been in business for over 135 years across 160 countries and employ over 114,000 people. You may recognise a few of the brands listed below there. Things like the Binax Now were our rapid antigen kits for things like COVID, Freestyle Libre for monitoring of glucose in diabetes, and a lot of our nutritional products there, things like Ensure, Pediasure and Pedialyte. So in all, we have 7 different divisions, some of which you may have had some interactions with, as I say, some of those nutritional brands, cardiac devices, and maybe even some of the neuromodulation care devices. But down the bottom there, we've got our diagnostics, which I mean, everyone has probably had some level of interaction with without honestly knowing about it. So the lab, we say, sort of sits at the heart of healthcare, with over 70% of clinical decisions informed by lab results, and 70% of your electronic medical record data being pathology results, lab results. And here we have a bit more detail of the core diagnostics division. So you'll see the instrument here. This is a uniform, multi-platform of instruments. So we've got chemistry, immunoassay, hematology, molecular, and even a much smaller handheld device, all with the same look and feel. So I guess if you think of it almost like your Apple, if you've got a computer and an iPad and a watch and everything, they all look really similar and easy for the medical scientists to use. And then as technology develops, we change a lot of the internal bits. So we cover a huge range of tests. I'm not going to go into them. Within each of these, there is a panel of tests. And Abbott sort of focuses a lot on medical research and improving clinical outcomes. So when we design a cardiac panel of tests, it's not just a troponin test for assessing myocardial injury. It's something that transforms patient flow through an emergency department. And it's something that understands that a woman's heart is maybe different from a man's, and so different requirements for cutoffs. And not just assessing an acute myocardial event, but assessing the risk of having a myocardial event in the future and at a point where you can actually make changes to your lifestyle and prevent it moving forward. We've also got a huge range of infectious diseases assays, which has created the Global Pandemic Defence. So this is a program that incorporates over 40 countries across 26 years, and this has been able to monitor pandemics like the one we recently had. It has meant that we have actually detected new strains of HIV, and because of all of this scientific leadership, it has earned us the ability to screen 80% of the global blood supply and 100% of Australia's blood supply. So we're really excited today to launch into our new space in neurology and our kick-starting, of course, in mild traumatic brain injury that we're here to talk about today. So without further ado, I would like to introduce you to our first speaker, Stuart McDonald, who's going to be presenting blood-based biomarkers to aid management of suspected mild traumatic brain injury. Stuart is a Senior Research Fellow and Principal Investigator of the Monash Trauma Group and Director of Fluid Biomarker Research in the Department of Neuroscience at Monash University. His research centres on pathophysiology of traumatic brain injury and the use of blood-based biomarkers to enhance TBI management. Dr. McDonald has published over 95 peer-reviewed journal articles and received $3 million in CIA funding. He currently leads large studies on blood-based biomarkers for mild TBI and sport-related concussion in collaboration with the Alfred Hospital and more than 100 Australian football teams. Thanks so much. Welcome, Stuart.
Thanks, Rachel, and thanks everyone for getting up early and coming in for this session. And yeah, it's a fantastic opportunity to share this progress in this exciting space. I think we're just on the cusp of fluid biomarkers really improving how TBI is detected and managed, and it's yeah, great to chat a bit about sort of what's happening and what we see happening in the near future. That's disclosures. So what I'll cover in the next 25 minutes or so is probably very quickly glance over what mild TBI is. Obviously, I'm speaking to an audience who's well versed in this. We're going to focus on the use of head CT scans in the emergency department, the need for objective tools for assisting in mild TBI and concussion detection and management, focus on blood-based biomarkers, what candidates there are, what we know about them, and then a selection of my recent work that I've done in this space, or my team has done in this space, and then finally focus on probably the thing that's going to be used clinically first in Australia, and that is using blood biomarkers to predict the absence of acute intracranial lesion on head CT. So firstly, just what mild TBI is. TBI itself is, the field is undergoing sort of a big change at the moment and trying to come up with a better way of classifying injuries, and with recognition that the GCS-based approach has its limitations. But for now, we still operate with this GCS score being the guide for this, with a 13 to 15 being the mild spectrum, which of course represents most of TBIs. Last year, the ACRM published a consensus new definition of what mild TBI was, and this, while it's somewhat controversial, where it's quite an important concept, I guess, particularly for research, that we do have a consistent, I guess, threshold and terminology used for the consensus or for the diagnosis here. And there are other working definitions, but this is one that is sort of taken, a lot of people have taken this up, and has a lot of similarities with other guidelines as well. But really, the main important thing is that it's a plausible mechanism of injury, that for a diagnosis, all you need is one of the clinical signs, so that is loss of consciousness, amnesia, and then the symptoms, that if there's two or more symptoms, then if there needs to actually be, a clinical examination, so whether that be a cognitive deficit or oculomotor deficit, something like that, to have the diagnosis of mild TBI. So basically the summary there is, if someone's symptomatic only, then they're put in this suspected mild TBI category. Now, this is quite different to sport-related concussion, which doesn't have criteria, but rather a definition. And there isn't a sort of a minimum threshold there for the level of symptoms, which I think is a good thing. It does create a bit of issues when it comes to inconsistencies with diagnosis, particularly away from the sporting field. But basically the same principles are there, where it needs to be a plausible mechanism of injury, the symptoms are not better explained by confounding factors, and importantly, you'll note, perhaps, I'm not sure if you can read that on the slide, but if there's an abnormality on neuroimaging, then that would be considered above the threshold for sport-related concussion. So they're not necessarily the same, even though sport-related concussion is a form of mild TBI. Sport, even though that's what most of my research is in, is actually only a very minor percentage of all the TBIs that are experienced in society. And you look at falls are the major cause, particularly in Australia. Motor vehicle accidents, assaults are the other leading causes. But this definitely varies when you go across the world based on the socioeconomic status and the Human Development Index. You can see this figure here, which shows that in the countries with a lower Human Development Index rating or score, that things like violence and road traffic accidents become a more common cause than falls, which is more in countries like ours and more developed countries. That falls are the predominant cause. The incidence is up there. This figure shows that it's greater than any other neurological disorder. So the incidence being the new cases per year. You can see on the right-hand side, that's TBI in blue, and the prevalence is the number of cases at any given time point. So there's around 50 to 60 million people worldwide suffer from a TBI per year. So it's a huge, huge issue. Major contributor to death and disability, costs a lot of money. It's a big problem in Australia and New Zealand as well. And what we do know is that this risk or the incidence does change with age. So younger children and adults are more likely to have a TBI, but the risk of death certainly increases with age into that older adult population. Big focus of this conference, you probably noticed that all of the quotation marks around mild TBI and throughout the program is for good reason, in that it's a bit of a misnomer, the term mild TBI. It's not always mild. So persisting symptoms, which commonly are defined as those that last for around 4 weeks or more, occur in 20 to 30% of cases. So for a lot of people, it's a really disabling experience, and sometimes these symptoms persist for much longer. Now, we do know there are some predictors for this. So the biggest predictor is just the level of acute symptoms that someone experiences, but also age, so teenagers, older adults. The females are more likely to have persisting symptoms, and pre-injury factors such as mental health problems, history of migraine, and concussion history are all big factors. Now on to the use of head CT scans in the emergency department, in the ED. These are some numbers from a publication from the US, but quite a large study that's probably reflective of the Australian setting as well. So we know that 90% of suspected TBI cases are mild, and around 82% will receive a head CT scan, so they'll meet criteria to have a head CT. So it's most people. But only 9% have an abnormality, so they have a bleed typically on CT, and in some cases, some studies have shown that to be as low as 5%. And only 0.5% are admitted to surgery, so have an actionable lesion that results in surgery. Now, we could just put everyone into a CT scanner, but I think there's several reasons why we shouldn't do that. That would be the best way of not missing a lesion, but if we did do that, we have a whole lot of drawbacks. So I think the biggest one is that CT scanners, well, they're pretty commonly found, but also you have to wait to put the patient in to get a scan. That results in longer wait times. Radiation's a big factor, so the level of radiation from a head CT scan is around 100 times what it is for a chest X-ray. So particularly when we're looking at children or even younger adults, it's not something you want to be doing all the time. Costs money, and also the sensitivity of CT to lesions is slightly less than MRI, which is even more difficult to organise. So we do need to really think carefully about how we triage patients for use of CT. With this in mind, there are guidelines that exist worldwide for how to manage cases of suspected TBI in the ED. So the Canadian CT head rule is one commonly used set of guidelines where I won't go into too much detail, but basically if there's loss of consciousness, post-traumatic amnesia or confusion, or someone has other risk factors such as being older, being on anticoagulants. That these are people who should be put into the CT. When you go across the world, this changes a little bit, but there's quite a few things in common. So the American guidelines, European, UK and Scandinavian, loss of conscious PTA, you need a head CT scan, but there's some other differences there, and I'll come back to particularly the Scandinavian guidelines as well. In Australia, it's a little bit variable. State by state, there's different guidelines, and from my experience working alongside sort of ED physicians, it tends to be quite different based on the doctor, but generally speaking, the same principles apply. So this is, I guess, where the fluid biomarkers come in is, well, we know two things. Firstly, that a lot of people are having CT scans that will show nothing, but also a lot of people have mild TBI or concussion that the CT scan isn't aiding anything to do with the diagnosis. So what my work focuses on is in large part looking at how fluid biomarkers might assist with this process. And we know that concussion, mild TBI is difficult to diagnose, and there's a lot of factors that make it so. So the signs and symptoms can be rapidly evolving. People might not want to report, there might not be a witness. So an objective marker, such as a blood test, could definitely help here. And I've already touched on the CT scanner. The question here is more so, who doesn't need to be scanned? Who can go home? So another big factor is prognosis. So I mentioned before, 20 to 30% of individuals with mild TBI do have persisting symptoms. We have some good factors we know are predictive, and there are some predictive models, but if a fluid biomarker can provide important extra information and predict who is more likely to have persisting symptoms, then we can have more earlier interventions and at least monitoring to help with these patients. My work largely is in sport-related concussion, and the big factor is return to play decisions. So there's been a lot of talk about minimum return to play in community sport extended to 21 days, and professional leagues for a couple of years now have had a 11 or 12 day minimum return to play timeline. But what we do know is that there are neurobiological changes that occurred in concussion and in mild TBI that can persist for longer than symptoms. So if we have a marker, and these unresolved changes might make the brain more vulnerable to another concussion. So if a biomarker can be used in that context to help provide important information about the brain recovery, then that will be very useful for clinical decisions. So most of the biomarkers that we look at have known associations with cells in the brain. So I'll go through this very quickly, but the main cells you've all heard of, neurons, so the wiring in the brain with the axons or the long projections from them. We also have other supporting cells there, so we have astrocytes, are a large predominant cell in the brain that play important roles, both structurally and with metabolism. Microglia, another type of glial cell, and also we have, of course, there's blood vessels there and the components of the blood-brain barrier. So when we look at potential proteins that might come from these cells that we can, if some of these cells are damaged due to a brain injury, some of these proteins can come out and make their way into the peripheral blood circulation. These are some of the main candidates we have. So the four I'll focus on today, and two in particular. So UCHL1, or ubiquitin C-terminal hydrolase L1, is found in the cell bodies of neurons. Neurofilament light, shown in yellow there, is in the axons. S100B is found in astrocytes, as is GFAP, or glial fibrillary acidic protein. There are other candidates, some of which we investigate, but these are probably the leading brain-specific candidates that we have some pretty good tests for and are using in research and starting to be used clinically worldwide. Apart from coming from different cells, these biomarker candidates and their associated pathophysiology have different kinetics. So they're both the process they're associated with, so axonal injury, inflammation, these things happen at different rates, but also the biomarkers have different physical properties, so different kinetics. So some are released straight away and disappear quite quickly, whereas others take longer time to peak. So together they sort of, there's some complementary ways in which they can be used across a different period of time, but we need to keep this in mind when we're using these biomarkers to assess an injury, for example. One that I'll just quickly go through that's probably been the most researched biomarker in TBI, at least up until a few years ago, is S100B. And the reason I brought it up here is that it has, for around 10 years now, been incorporated into the Scandinavian guidelines for ruling out need for a CT scan. So that's fantastic progress. I won't go through the diagram on the right there, but basically what it shows, if people don't fall into the high risk categories and they have loss of consciousness or PTA, then they have an S100B test, and if it's not elevated, then they don't need a CT scan, they can go home. The problem with S100B is that it has a really short half-life. You need to measure it soon after injury, so with the guidelines are within 6 hours. The other problem is that it's not terribly brain specific. So we do have things like a bone fracture, for example, which often happens in patients with mild TBI. They don't just come in with a head injury. That can cause an elevation itself in S100B. So it needs to be used carefully, and it's certainly good progress, but perhaps not the best biomarker for this use. I'll glance over this very quickly. It's probably very hard to make out there, but what this diagram shows is a study done a few years ago, basically looking at the properties of what an ideal TBI biomarker would be. And they've basically got, one is yellow. These are the top 50 candidates they found there. Yellow is that it needs to be enriched in the brain. It needs to be so brain specific. It needs to be abundant. It can't be a really lowly expressed protein. And also that it needs to be found sort of throughout the brain as well. It can't just be in one particular location, because obviously brain injuries can affect different parts of the brain. So the leading candidate that came out of this was actually a protein called GFAP, which is a structural protein found in astrocytes, highly brain specific, and has, as I showed, these properties that make it favourable as a biomarker. Now, as I'll show in a minute, one of its slight drawbacks is that it takes a little bit of time for it to rise in elevation in the blood plasma, whereas UCHL1, which is also very brain specific, it's found in different cell types, found in neurons, but it peaks really soon after injury. So when you look at their temporal profiles side by side, you can see that they're quite complementary. So UCHL1 peaks really early but then drops off, whereas GFAP takes a little bit longer to rise up and peaks around 20 hours. So together they have sort of create this larger sort of diagnostic window. I'll just touch on briefly some of the research that I've done recently in this space, or with my team, and actually this is a paper that John Reyes is sitting at the back there, was the first author on. John's a former postdoc from our group, and what this shows, this is a focus on CT negative mild TBI in the ED, and there's 4 biomarkers we've focused on here. So GFAP, IL-6, which is an inflammatory cytokine, UCHL1, and neurofilament light. And what I want to show just quickly here is that the red, which is the mild TBI or concussion, compared to the blue, there's, for all 4 of these markers, NFL note that that's actually at a different time point. We've got these patients back at 1 week, but basically there's quite a good separation between the red and blue, which indicates good diagnostic utility. But also within the mild TBI, you notice that this is these are on log axes, that there's quite a spread. So people coming in with varying levels of these proteins. I'll skip over that. This here just shows, for those familiar with diagnostic tests, we use this. The main sort of measure is this area under the curve measure, where a 0.5 is basically flipping a coin. A 1 is a perfect test. Obviously, we want all tests to be closer to 1, but sometimes sensitivity and specificity is dependent on the circumstances. But basically what I'm showing here is that the top in purple there, that GFAP and UCHL1 across the spectrum, so all mild TBI cases, but also if we break them down into those with or without loss of consciousness or PTA, and in males and females, has an area under the curve of about 0.85, which is very good. Whereas at 1 week, NFL, neurofilament light has the most utility. Okay, this one's figure didn't turn out as planned. Okay, it's missing all the dots. But what I will say is basically we're just finishing up a big study. We've done this specifically in sport-related concussion, which traditionally is considered the mildest end of the mild TBI spectrum, where we've shown similar values where we measure it on the next day, which is really convenient for more feasible in a lot of community sport settings, that GFAP has a value of around 0.85, which you cannot see all the dots on the graph there. We published a paper earlier this year on looking at GFAP and some other markers in the context of neurobiological recovery. So this is a really large study. We had 140 players of Australian football that each had 8 blood samples over a 6-month period. And the focus here was not so much on the diagnostic component, but more how these changes in proteins evolve over time. And what we're really trying to do here is tease apart sort of different subgroups. We know that we knew to that point that, like the clinical phenotype, that the neurobiological phenotype is likely to be quite heterogeneous. And you can see that pretty clearly when you look at the spaghetti plots here. That just shows basically the GFAP levels over time. On the left, you've got the controls. On the right, you've got the concussion. 2 things sort of stand out to me. One is that almost everyone has a decreasing GFAP level from 24 hours to 1 week, but some people actually have a more prolonged elevation, or in fact, sometimes looking like a secondary peak. Now, what the take-home sort of from that study was, we think that this provides good rationale for using these biomarkers to measure serially to track recovery. But while we wait to get to that point for FDA and TGA approval, one sort of take-home message we had from this paper was that the extent and duration of these biomarker elevations were much larger in patients, participants who had lost consciousness. So you look both at 24 hours, out to 4 weeks, those with loss of consciousness had elevated levels compared to those without. So the take-home was that perhaps these athletes, or people who recognising suspected loss of consciousness or is being reported, should be considering more conservative return to play timelines. So with that, I'll finish up on my research and go into sort of the most relevant research to the Abbott assays and their hopefully near use in the Australian setting. And that's looking at blood biomarkers, particularly GFAP and GcHE1, in the context of CT scans. So sort of the first really big study that created a lot of movement in this space was published back 5-6 years ago, run by Jeff Bazarian and colleagues in the States, where there was close to 2,000 TBI patients that mostly GCS 14 and 15, so then the mild TBI, had blood sampled within 12 hours and met criteria for a CT scan. So they all had a CT, and then they had GFAP and GcHE measured with this Banyan test, which is a test that took around 4 hours, so not terribly useful for immediate decisions. It was more of a proof of concept at this stage. But what I'll draw your attention to is the red columns there, which are the mild TBI. That basically the middle two here, you can see that for those who had an intracranial abnormality, had a lesion, the GFAP and GcHE1 levels were much higher than those without. Now, fast forward a few years, Abbott have created a test that can be run much faster. So it's for these same 2 proteins, GFAP and GcHE1, tests that can be run in 15 minutes. Looking at these, this alert TBI cohort with predetermined cutoffs. They had a cutoff of, based on previous work, that an elevated level would be a GcHE1 level above 360 picograms per mil, and a GFAP elevation would be anything above 30 picograms per mil. What you can firstly see if you just look at the CT negative and CT positive case, so on the left you've got GcHE1, the red being the positive, that there's again that same difference was found with this much faster rapid test. And it's very pronounced on the right-hand side. You can see that CT positive cases had much higher GFAP than CT negative. Now this is all great, but how do you actually use this information? How would an emergency physician make best use of this? And what the actual best use of this, and I believe, and this is I guess the consensus in the space, is that it's not so much determining who does have a lesion on CT. It's more ruling out unnecessary CTs. So who doesn't need to have a CT scan? So it's a negative predictive value. So who's going to be, has a negative test result and truly have no lesion on CT. So when you look at the breakdown of their cohort, you can see, as I mentioned before, the vast majority of people don't have a lesion on CT. Now, of these, 720 had a negative biomarker test and 1,061 had a positive biomarker test, which you might think is a large number of false positives, but I'll come back to why I don't think that's an issue in a minute. For the CT positive, you can see there's a really good ability to predict those who actually had a lesion on CT. 115 of those had a positive biomarker test and only 5 had a negative test. So when we look at diagnostics, I don't want to get into this in too much detail, but you've probably heard of terms, or you may know this very well, but we talk about sensitivity and specificity, but really what's important in this context for a test to help rule out need for a CT scan is a negative predictive value. So what we really don't want, you can see in this bottom left corner there, is a false negative. So someone who would test negative on the blood test but actually does have a lesion. When we look at how you crunch the numbers for how this performs here, the sensitivity is around 96%, but the negative predictive value is over 99%. So really good ability to determine who doesn't need a CT scan. And if you look at the numbers here, basically if you were to operationalise this in this context, around 40% of CT scans that were performed could have been avoided, which if you think about how that applies to the ED, it's meaning that a lot of extra resources are being freed up, and also other patients are getting the care that they need. They also looked at this analysis a bit broken down into some other sort of subgroups. So if we look out, they looked just within 2 hours. So people who came in quite acutely, the negative predictive value was actually 100%, and this is in the case of the subgroup that had just GCS of 15. So those who have the highest scores. In terms of the false negatives, so people might be interested, well, okay, what about the 5 people who would have been sent home but actually did have something that could have been detected on CT? In this study, and a number of others have shown this too, that all of these cases were not actually actionable on surgery. So these people wouldn't have needed surgery based on their CT findings. Subsequent to this, there's been a sort of big series of studies that have tried to really extend on this and get these tests being used worldwide, and comparing how GFAP UCHL1 on the Abbott platform works on the Roche platform, so compared to S100B on the Roche platform, given that that's being used in the Scandinavian guidelines. And this is a study published by Dr. Okonkwo and colleagues a couple of years ago, focusing on comparing these two and their ability to separate those with and without a lesion on CT. And then you can see the black line there being GFAP, and then the red line being S100B, that the area of the curve is much higher for GFAP. And this wasn't just over a 24-hour window. This was actually even in, I don't know if you can see it in the bottom part there, but that was all of the windows from 0 to 6 hours, the whole way through. It performed much better. As I mentioned at the start, I find it a really exciting field to be working in, and I'm really looking forward to what the future holds for how we're going to start turning this from research into clinical management. And this is just a selection of other papers that are coming out. So there's been those that have shown, validated these findings of GFAP UCHL1 with the Abbott platform in other contexts or other cohorts. Studies showing how much money this can actually save. Also looking at some more of the intricacies, so well, can we use these same cutoffs for children, older adults? Some complexities there we need to consider. We're going to continually to refine these to cater for all individuals. 2 big consortium, there's one in the US called Track TBI and Europe called Center TBI, that have thousands of TBI patients, have shown that these 2 biomarkers do actually add value to existing prognostic models for predicting those who will and won't recover well from TBI. suggesting potential use in that context as well. And also showing these tests can be used beyond that 12 hours and in fact out to 24 hours, there might be utility. Just finish here by showing a preprint. So this isn't actually publication, but it's sort of the international meetings I've attended recently. Biomarkers are taking over this space, and I think it's a good thing because everyone in the field, even if they're not a biologist or a scientist or someone who's a bit of a biomarker skeptic, recognises we need better ways to classify and characterise TBI. And biomarkers are going to be part of that. Not the whole part, but a big part of it. And this preprint, I think particularly for me, struck home in terms of how biomarkers actually might be particularly useful in that mild end of the spectrum. So again, this might be a bit difficult to make out, but what they've used here is effectively this item response theory to model the utility of different aspects of both what you'll find on a CT scan, clinical features, so the GCS, loss of consciousness, PTA, but also biomarkers, and how their utility changes across the spectrum of TBI, so from the left being the low end to the right hand. So and what you'll probably notice is the top two there, which is the imaging, and then on the top bracket, and then the middle one, which is the clinical signs. They're pretty good indicators of severity, or have a large number, have good importance when you go further to the right, so more severe forms of TBI. But on the far left, which is where the majority of cases are, they don't really tell you that much. You get a little bit from loss of consciousness, PTA, but what they've found in their 2,500 patients is that GFAP and UCHL1 are actually quite useful, and particularly in that setting. So with that, I'll finish up and pass it on to Dr. Terry Moodley.
Thanks, Stuart. That was a fantastic summary of some exciting work being done right here in Australia. My name is Terry Moodley. I'm the Medical Director for Abbott Core Diagnostics in Australia and New Zealand. What I'm going to take you through is just how does all of that research translate into actual clinical practice, and where are we from that perspective. So Stuart's done a great job of explaining to you what our current standard of care is, the CT scan, and he's also elucidated on all the limitations. It's a fantastic test, but there are limitations, the variable criteria that he showed both internationally and locally, the fact that there's not always a CT scan available. We're very fortunate here in Australia to have access to amazing resources, but rural, regional, and remote areas especially do not have the access to CT scans. The time, the waiting period that we've had discussions within a busy ED trauma department, the waiting time for a CT scan in the last 18 months has gone from 2 hours to 4 hours. And it's not just that single patient that's having to wait, it's the whole cascade domino effect that it has on ramping in ED departments. There's the fact around cost. A CT scan costs a few hundreds of dollars, a blood test usually tens of dollars. There's the radiation, which Stuart has mentioned is 100 times more than a CT, chest X-ray. The accuracy and the challenging patients, and I mean this in the best sense in that sometimes you have elderly, delirious patients, drunken patients, and to get them to lie still through a CT scan for 5 to 10 minutes is a really difficult process. So being able to do a blood test in a matter of seconds might be much more appropriate. And Stuart's also done a great job in elucidating why GFAP and UCHL1 are potential utility, have high potential utility in clinical practice, mainly because of their high neurospecificity from their location in neuronal cells and the biokinetics, which he spoke about as well. So I'm not going to spend any time on that. Bearing out of that and the pivotal studies that he quoted from Bazarian et al., the Abbott TBI test has now been registered in Australia for use, and the registration with the TGA allows it to be used in that context of a patient who has had a mild brain injury, presents with a GCS of 13 to 15, is an adult patient presenting within the first 12 to 24 hours to ED department, and the doctor should take into consideration the clinical picture and then decide whether to do the test or not. And the test, as Stuart again has mentioned, is to rule out the need for a CT scan. Because if you do the blood test and it's negative, it correlates really highly with the absence of any CT finding. So in practical sense, how would this work? The patient would present to ED with the mTBI. You'd have a blood sample taken, which would then go off to the lab. Once the lab receives the blood sample, they can do the test on the machine within 18 minutes, and then you get a positive or a negative result. Stuart mentioned the cutoff points, but the way the result is actually reported, you'll get the actual quantitative value, but the result is reported as a positive or negative. It is negative if both the biomarkers are below the cutoff point. It is considered positive if one or both are above the cutoff point. If they are both negative, that means you probably don't need to do a CT scan. How is this translated internationally? Well, you can see here that the French guidelines were published last year, and they've included into their management protocols the use of the biomarkers for filtering out unnecessary CT scans. And they've said that the utility has been proven through the various studies. I'm not going to go into detail there. Earlier this year, the Spanish medical fraternity, made up of pathologists, radiologists, sports physicians, and ED physicians, came out with a consensus statement, and they again endorsed the use of the test. Sorry. Where are we? Yeah, there we go. They said that the use of the test can reliably predict the absence of acute intracranial injury, and that this is a paradigm shift in the way in which this condition can be managed. In the US, various societies, including the College of Emergency Physicians, the Rehab Medicine Society, and the NINDS, have come out in support of using the test. The emergency physicians, again, say that this could be used to reduce the number of CT scans. The rehab physicians have taken it even further because the research, as Stuart has shown, is starting to show that you could use this even in starting to look at diagnosing the condition. And the NINDS have said that this could assist in reclassification of TBI, so suggesting that the way in which we define TBI should start including biomarkers in the very definition thereof. Practically, it's been used in several countries. I've quoted a few here. This is mainly in Europe, and if we had more time, I'd test you on what those flags represented. But that's actually in mainly Eastern Europe with Croatia, Italy, Spain, Estonia, etc. And you can see the performance there in terms of sensitivity and NPV, or negative predictive value, correlates well in the real world to the kind of findings that were found in the research setting. So the test is performing as it should in the real world. A couple of weeks ago, there was a European consensus statement with experts from Spain, Germany, France, etc., that looked at the evidence, and they've said that there is strong scientific evidence that GFAP and UCHL1 can be used for assessing the need for a CT scan and to reduce the need for unnecessary CTs. This is some of the recommendations they made. I'm not going to go through it in the interest of time, which we are running out of. But most pertinently, they suggested an algorithm. You may not be able to see it there, but essentially the blue colors is your normal clinical assessment. You look at the history, you look at the signs, you examine the patient, etc. In the orange line there, you're then saying, should I do a CT scan? And then in the teal color, what they're suggesting, and this is where the change is, that instead of just going straight to the CT scan, you do the blood test and then decide whether to do the CT scan. And the benefits of that, again, we've discussed, the reduced in radiation cost, time, etc. And so that's quite significant. So where are we in Australia with this? Very quickly, it is TGA approved, so it's available for use, especially in labs that house the Abbott equipment, which is quite a significant number of your public and private sector laboratories. There is a lot of work going into educating of healthcare professionals across the spectrum, allied health and clinical specialists like neurologists, radiologists, ED physicians, neurosurgeons on the utility of the test. We have 2 sites across different states that are about to implement a validation study this month, and about 5 sites that are looking at early adopter processes or programs in the next couple of weeks. We're working with a couple of the sporting bodies to look at how this can be included into their protocols, not just for return to play, but also in terms of long-term prognosis, etc. And there's a lot of research going on. Stuart gave you some idea of some that's currently underway, but there's lots going on in terms of other indications, age groups, gender, prognosis, and outcome work as well. I have no doubt that on the basis of all of this, that this assay will in the future become the standard of care in managing TBI in the same way that Rachel mentioned earlier, the way cardiac care has changed with the use of biomarkers beyond just using ECG tests. And so on the basis of that, I'll just wrap up by saying what we've tried to show to you over this hour is that mild traumatic brain injury is a focus for a lot of research and clinical care, and you're part of the core area, so I don't need to take that any further. There is a need for improved tools beyond just the CT scan, and GFAP and UCHL1 have been shown in practice and in research to fulfill that need, and that a lot of this evidence has led to inclusion in clinical guidelines. And locally and internationally, there are a lot of sites that are starting to use it with the ongoing research. So we hope that you have been informed, you will become part of that process of adoption and lead to better patient care and outcomes in the near future. So thank you very much. I was going to say that you could have a second round of breakfast, but I see they've cleared that up. We probably only have a couple of minutes for questions, so if Stuart will join me up here, we've got the master, young Blake, roving around with a mic, and we're happy to take some questions. Just a couple, because they need to turn around.
Hi, my name's Jackie, and this is a question to both of you. Firstly, thanks for your presentation this morning. I work in brain injury rehab, and that does include early management, post-concussion and mild TBI. And one of the dilemmas that we often experience is if someone has had their accident at work or in a car accident, quite often insurance won't pay out for support for therapy or recovery because they will say that the person's making up the problem. And so my question is, could biomarkers be used to confirm particularly PCS, so that we then had some evidence to support people and not have them being fobbed off as making stuff up, when we know that their lives have been remarkably impacted?
Thanks, Jackie. Great question. And certainly a lot of the neurologists that we talk to tell us that they don't get involved in the acute phase of this pathway. They get involved when it reaches that point of medical, legal, and things. And as Stuart has mentioned, and he can add to this afterwards, there is research that shows biomarker elevation in terms of acute phase, intermediate phase, and prolonged phase. So certainly, it does offer the scope of an objective test that says, yes or no, this person has it. The test is not currently indicated for that, so I have to make that very clear. The research suggests, and it is evolving, that it may get to that point, but that's where we are, at that first phase of that. You want to add anything?
Yeah, no, I agree, and I think that's where we're going to be heading, in that I think it's probably going to be this aid in diagnosis, or is going to be used in a way where concussion is always going to be defined based on its clinical presentation, and this isn't going to change. But what it does give you is some ground truth there, and as I showed in some of the slides, some of them didn't work, but that even in those, for most people with concussion, they do have elevation in these biomarkers, and where it really becomes more useful is perhaps not when you have the more overt signs, or someone where there's several witnesses, but someone where there's some question of whether there is injury or not. And this, in many ways, is the ground truth for that, I think. So it's not, I don't see it as being the case if you don't have elevated GFAP, you definitely don't have a brain injury, but more if you do, you almost certainly do have a brain injury, and that's potentially one other use where it can be used. That's a great question, yeah.
Blake, there's one down there.
Hi there. I'm just wondering, the test has been approved for adults. What's the research like for children and adolescents? Because obviously there's a lot of sporting concussions that happen in that cohort.
Yeah, so again, we'll tag team in the response here, but currently the test is registered for adults over the age of 18. As you've seen from some of the research, I think Papa et al. Have done a lot of work in the different age groups. Stuart showed a paper that was published a few weeks ago that looked at the different cutoff points for different age groups. So I think, again, the science is evolving, and without having a crystal ball, I anticipate that indications in children, et cetera, will follow, but possibly with different cutoff points, et cetera. You want to add anything, Rick?
Yeah, so there's a paper, Rebecca Mannix published a paper in Neurology a few weeks ago that did show that, yeah, that as to be expected, that these biomarkers are not, they're found at different levels. Actually, GFAP is at higher levels in younger children. So if we use the same cutoff, you'd be putting a lot of kids into the scanner unnecessarily. So the same process is no doubt going on now, not in my work, but others we're working on exactly what should the cutoff be to achieve this level of performance that we need for it to actually be widely adopted. So I'm sure that will be in the near future.
Okay, I think we've run out of time, so if you have any other questions, please feel free to catch Rachel at the stand outside. We'll be around for a day or two. Enjoy the rest of the conference, enjoy the rest of the day, and thank you for the great work that you do. Have a lovely day. Bye-bye.